Dr. Victor Asari Bampo was appointed as the acting chief executive officer for the National Health Insurance Authority in January 2025. Until then, he worked for the United Nations as the UN Joint Program on HIV/AIDS Country Director for Kenya and its representatives to the UN Habitat and the UN Environment Program. Before September 1, 2024, Dr. Victor Bampo was based at the UN AIDS Global Center in Geneva, Switzerland, where he headed the Partnerships for Program Implementation Department and was responsible for his organization's relationship with major funders like the US PEPFAR and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. A former Deputy Minister of Health in Ghana, Dr. Bampo was the incident commander for Ghana's Emergency Operations Center, which prepares for and responds to public health emergencies, including Ebola. In his immediate past role, Dr. Victor Bampo served on the Strategy Committee of the Board of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and was until recently an alternate board member for the UN AIDS constituency, which is made up of 11 UN co-sponsors. Dr. Victor Bampo worked extensively with the WHO, Gavi, UNICEF, the UNFPA, UNDP, Stop TB, and other partners, and has a good network within the global healthcare architecture, both at the headquarters and at the regional and country level. He is experienced in building partnerships with civil society, government, and bilateral and multilateral partners. Before serving in government and joining UNAIDS, Dr. Victor Bampo served for 10 years in various capacities at the Global Fund in Geneva, including regional manager and senior fund portfolio manager.
And it's our guest tonight on The Point of View. Welcome.
Thank you very much, Bernard.
You were appointed January this year, so
Yes.
you've done 10 months.
Yes.
Are you able to compare this to Deputy Health Minister you were in Mahama's first term? How different are the two roles?
I think it's a different time as well.
Okay.
So, you know, especially with the U.S. stop work order, which means that countries like ours don't have enough resources. We have to make better use of what we have. So I think I'm at a very important place, and I thank His Excellency the President for giving me that opportunity.
So you are thinking more about money to make healthcare accessible.
Absolutely.
That's the focus.
Absolutely.
But that's what you've been doing your whole life, mostly, right?
Yes, but
or at
you
least for a
see-
big part of your life in the Global Fund.
Yes, but you see, at that point, I was working on the donor side, and the donors would bring in hundreds of millions, and you could put in place what I like to call the Rolls-Royce model, you know, of any kind of programs that you wanted. But now, money is not, you know, it's scarce. So you need to think very hard. And if a Toyota Vitz model can do, you use that, because it's about saving lives and getting people to have good health.
But NHIS is more like a spending entity. Or do you generate any money on your own?
So we are a spending entity. One of the things we're trying to do is to move away from being a claims payment mechanism to a strategic health purchasing provider, which means that we are able to dictate, you know, health outcomes because of the financial muscle that government provides us with. We're able to determine the prices of medicines, the prices of services, and even go onto the global stage and give Ghana some kind of platform to discuss what kind of health outcomes we want, as you saw with the Accra Health Sovereignty Summit that happened on August the 5th. So it's an interesting time, and His Excellency the President, the Minister of Finance, and the Minister of Health have given us the tools to be able to deliver on this mandate.
So just explain a bit more when you say you want to move away from just being a claims payment mechanism to a strategic health provision, something.
Okay, so essentially the health insurance scheme, you know, set up in 2003, Act 650. It was amended in 2012, Act 852, and is to pay claims. But now, what we are looking at is getting universal health coverage for all Ghanaians. And universal health coverage has 3 pillars, where there is population coverage. And I'm proud to say that we are at 20 million, which is unprecedented, and we'll come back to that. Yeah. And then there is service coverage, making sure that every Ghanaian living everywhere can get a service. And then there's financial protection, which is one of the main pillars, one of the 3 main pillars of universal health coverage, which means that every Ghanaian living everywhere can access quality health care without financial hardship. And that's very important. So it's not just paying the claims and, you know, that usual banter about, our claims have not been paid and so on, but making sure that we are the bedrock of the reforms that will lead to better population coverage, better service coverage. And for example, we are part of the thought leadership under the direction of the Minister of Health, designing the free primary health care program. We are also supporting the Ghana Medical Trust Fund to develop the Mahama Cares program, which is looking at non-communicable diseases. Why is this important? It's important because 20 odd years ago, when the National Health Insurance Authority was set up, what was causing problems for Ghanaians mainly were communicable diseases, malaria and so on. Now, because of the epidemiological transition, our lifestyle and so on, non-communicable diseases, or what we call the chronic diseases, are taking up fully 40%, 45% of our all-cause mortality. And so we've had to pivot. Now, Mahama Cares is benefiting from the work that we've done over the 20 years as NHIA. So we are also thought leaders in that area. So when I say becoming a strategic health purchasing provider, that's what I mean, that we are using our influence and our knowledge to affect the way Ghana's healthcare delivery is being set up. Free primary healthcare is also looking at a basic minimum package of health services for all Ghanaians, free of charge, from promotive to preventive to curative. So you go to any CHIPS compound, you go to a health center, you go to a maternity home, and you should be able to get some of these services.
No, this is great. The question I have though is, do you control the sources of money you get? Because I know we do pay an NHIL levy as part of the VAT, which has been decoupled and whatever. And then there's also a tariff. So how does that work? Do you determine how much money you get, or this is purely dependent on the finance minister's largesse? Well,
it's dependent on the importance that the government puts on healthcare. And that's why I'm so proud of His Excellency the President, his Finance Minister, and the Minister of Health, because I'm sure you remember the Capping Act 947, which came about in 2019, which put a cap on the funds that were coming to the NHIA.
In addition to others, I think Get Fund was also capped. Exactly. A couple more were capped.
There were quite a number. Yeah. Now, the president, during his campaign, he promised that he was going to remove that, and he has removed that. So we have an extra 3.5 billion cedis that have come to healthcare. Now, what that means is that we have more funds to do more. Now, what we are trying to do also is to do three things. Number one, to get people in government and across the country to have a mindset shift, which looks at how health is important to the development of the country. So, for example, now you hear the Minister for Finance actually advocating for us, because he knows that health is not a cost center. It's actually an investment driver. So when people are healthy, you can be more productive. The second is the focus shift, focusing on specific areas where we can have the best bang for buck, like Mahama Cares, like free primary. Now, if 40+% of people are being, taken away by non-communicable disease, then it's a good idea for us to try to turn off the tap. And how do we do that? By preventive actions, by promoting healthcare, by doing screening. So, for example, if you have a man with prostate cancer at stage 4, and you catch him later, it's better to do what we call a PSA test to see it at stage 0 or stage 1A or B, so that you can. It's more cost effective to manage that case. So once you have that focus on the right areas, you can also reduce your expenditure, and the general health outcomes are better. And then the third one is the reality shift. And I talked about that earlier, that, when I worked at the Global Fund, and to a certain extent the UN, and the US government, through PEPFAR, was providing support for HIV and AIDS. And some of the programs are really comprehensive, but they're expensive. And we may not be able to afford it in that fashion. So if you want to go from here to Circle, you can go in a Rolls Royce, you can go in a Toyota Vitz, you can go on a motorbike. It's important that you get there. So we are trying to look at things that fit within our reality,
okay,
so that we can deliver.
Let me understand the 120% tariff increase. So already you have the uncapping of the fund.
Yes.
3.4 billion has come in.
Yes.
This tariff, who charges it, and how isn't 120 too sudden, too high?
So maybe to explain a little bit, and just to say that I need us to dial a couple of steps back.
No problem.
So what we are thinking of is that we've done the work and we think that it should be a 120%.
You are proposing?
We are proposing.
120% increase.
Well, it was, it was done by a group of experts. Now, what the law says, Section 33 and 34 of our law, says that every year we must review the service tariffs and the medicines tariffs. We've already looked at the medicines tariffs. Now, the service tariffs, I think the work was started by my predecessors in 2022. But this was there are two types of review that we have to do. This was a really comprehensive one. So I think they could not finish on time.
Okay.
And it's now that they finished. And they're proposing that we do 120% increase. It's gone beyond the, doing it every year, but it's important. Now it has to go to our board for them to look at it and give a, give their view on it. Number two, it has to go to the Minister of Health to give his accent, and then we would then implement it if all of them think it's okay. Why we are not worried is that we have another challenge.
Okay.
And the challenge of illegal, fees at hospitals, where one of the points, the areas of contention, I have a 3-point vision, and one point is looking at patients having a beautiful experience when they go to hospitals. In many hospitals, that is not happening now because they are asked to pay out of pocket. Now, the health providers tell us that we are not paying realistic tariffs, and that is why that is happening. We think that once we pay those tariffs, then there will be no excuse for the health providers to ask patients to put their money in their pockets to pay.
I see. Let's look at this, the overall health of the NHIS. I think you sent us a couple of slides on the amount of money that comes in. From what I see from what you sent us, consistently there's a lower amount of money you get than what is actually the allocation. It seems as if maybe if X amount is allocated, you always get a lower amount. Is this correct? So what is this?
Okay. So the first slide, because as you rightly said, 2.5% of VAT comes to the National Health Insurance Fund, which is then given to the authority. So there's some, and then there's also some funding from SNIT. So the gray line is actually looking at the projected revenue that will come in. So that's the top line. The blue line is actual transfers. Oh, no, the red line
is actual transfers.
Is actual transfers.
So the red line is always lower than the gray line.
And yes. And the blue line is the budget allocation. So for example, last year, the allocation was 6.5 billion. This year, the allocation was 10.07 billion. For 2026, the allocation is 11.3 billion. Now, if you look at the gap between the first line and the second line from the top, you would see that from 2019, and I'm sorry, this version doesn't show.
I'll show a proper version as the program proceeds.
So from 2019, there's some sort of gap between the gray line and the blue line.
Yes.
And how is that explained? It's explained because there's a difference between the projected revenues and what is in the budget. You understand? So for example...
So they always allocate lower than what you are calculating you will get?
No, because of the Act 947. So let's take 2020.
The capping?
Yes. So 2024, the anticipated revenue was 9 billion. But then in the budget, they were given 6.5 billion. And what was actually given to NHIA was 5.9 billion.
Fair enough.
So there's that gap. So that gap. Now you see that for 2025, that has closed. So the gray and the blue have merged.
The gray and the blue should be one line.
Exactly.
So what has happened is that between 2019 and 2025, there's been a gap.
Exactly.
But the red is always below, anyway.
The red is always below because it depends on how much collections there are and how much is transferred to the NHIA. But what I can tell you from 2025 is that even though the red is below, as at now we project to be at about 8 or 8.5 billion out of the 10.07 billion. But I can tell you for a fact that there is no facility that would say that we've not paid them if it's not an operational issue. It's not, I brought some of these to show you. A few years ago, private health facilities were sometimes complaining, withdrawing services because they've not been paid for 9 months and so on. Now we are on a regular, predictable path where every end of the month we pay all facilities. Now, if you go out there, would you find some facilities that have not been paid? Yes. Kolebu, there's some months that they've not been paid. There's a reason. It's not because of finances. It's because some of these facilities are very big. Okay. They have 90 days to bring the claims. And then for facilities like Kolebu, we need maybe a month to do the review.
I see.
So it takes some time.
We will come back to this chart later to look at the proposed financing health reform. But to look at the health of a scheme, beyond the fact that you have enough money, it's about whether the card actually is accepted.
Yes.
There was a story done by the Fourth Estate last month where a number of state-sponsored facilities were actually refusing or turning away people who came with Ghana card, the NHIS cards. UGMC was one, Legon Hospital was another, Trust Hospital was another. Apart from apart from Ridge Hospital, which is the Accra Ridge Hospital, and I think 37, a lot of the facilities they visited, when you said you had a card, they would say go to another hospital. Now their concern is Bank of Ghana Hospital, the hospital in Tema, which are all supported with state funds. Why should they say no to the NHIS card?
So that's an interesting question, and the truth of the matter is that some health facilities have not signed on because you have to get your accreditation, and then you are able to accept the card. I know for a fact that UGMC has not subscribed. They are a quaternary health facility. I think Bank Hospital as well. But we must look at it within a certain context and remember that perhaps these facilities that you've mentioned, there's a little bit of selection bias, I think, because we have 5,000 facilities. And every day, even as I sit here, some of my former classmates who are working in the US and so on, I can give you names, people who've set up here and call me and say, can you help me to get our paperwork right? So if in the larger scheme of things, it is working. Remember, no,
I'm not saying it's not working. This is more a question of discrimination by the facility. So this is not about whether the card is good.
Yes.
I think the concern for the story was that International Maritime Hospital, UGMC, Trust Hospital, and then BOG Hospital, which are hospitals which are highly resourced.
Yes.
With public funds.
Yes.
Why are you saying that the basic insurance card that's supposed to give healthcare to Ghanaians, they don't want to recognize it?
So I want to flip it around. And Bernard, I'll come to that. What I wanted to say was that let's start with what's working and come to what's not. So remember that the health insurance scheme is the largest social protection scheme or program in Ghana. As we speak now, an unprecedented number of people have subscribed to it. We wanted to reach 20 million at the end of December. Just a few days ago, as you rightly said, my minister announced in Parliament that we are over the 20 million. That's 60% of people. We are using data to guide the way we enhance the products that we have. And we are using it as a basis to get better health. I talked about free primary health care, and I talked about Mahama cares. So for a large group of Ghanaians, it is working. Secondly, I cannot speak for hospitals like UGMC and Bank Hospital. I do get the point, though, that it would be good if they were using it. But there are alternatives. Because you mentioned all these hospitals, but there are also a raft of hospitals. If it's not working in one place, you can go to another place. Because, and like I said, I'm not speaking for them. Some have made some investments they want to recoup and so on. That's fine. But
does that, my concern is that does that suggest that for a hospital like that, accepting the card lowers their financial viability? Because
No.
if you are paying, because don't forget that we were told about 30% of NHIS covers 2 major NCDs. Again, this was said just last week. I think they mentioned hypertension and diabetes.
Okay.
So it looks like a lot of lifestyle disease-bearing people depend on your card.
Yes, that's true.
Okay. So I'm just saying, if is it that for them, if they accept the card, it impoverishes them as a hospital? I don't understand.
I honestly
because if the system is financially viable, why shouldn't they be happy to accept the card? But they accept private cards and they do cash out of pocket.
Bernard, where we want to get to, and I'll be the first to admit that we've had challenges and we want to put those challenges behind us. Where we want to get to is that the card will be so attractive that all the health providers in this country would want to use it. And we are, I think, on our way to getting there. Last year, by this time, we had 1.5 million fewer Ghanaians on the card. Now we are at 20 million. We would, I think, get to 21 million by the end of the year.
Let's be clear. 20 million, does that mean active users of 20 million Ghanaians possess a card? That's not the same thing.
So 20 million who have registered this year to use the card. So every year we do a registration. Okay. Every year. So you need to renew. So 20 million Ghanaians actually have the card. So if they fall ill, they can go and use the card. That's what it means.
So they are willing to use the card for this year? Or they may be using the card?
Yes, exactly.
So which means it's possible that more people possess the card. Because, for example, I have a card. I don't think I've renewed this year.
Yes, so you are not part of you are not one of the 20 million.
So which I want you to separate usage from card ownership.
I think card ownership is important because they've taken the trouble in 2025 to renew.
But don't you also want to tell us active usage? And also then that gives you a better sense of which areas the card may be functioning. So beyond 20 million, what percentage would you say in a year use it like at least once?
No, so we have all that data.
But we need it.
No,
why are you giving us only the 20 million top line figure?
Because
we want to know how many people use it.
Because it's more important to be prepared.
But because, you know, there's access, availability, affordability. You yourself explained that there's, you told us there's financial protection, there's service coverage, and then there's
geographical coverage.
Beautiful.
Yes.
So the 20% is geographical coverage. 20 million. 20 million.
Yes.
That's 60% of Ghanaians. What is the service coverage? And in reality, how many would you say if they went to a hospital today, it would work for them? I think that number is important.
No, it's important, but you see, it gets a bit conflated, and I'll tell you why. Because some people use it 2 times in the year, 3 times. So I can tell you for a fact that maybe 17 million or 15 million have used it. But then we have to then disaggregate it and say one person has used it 4 times or one person has used it 3 times. So for us, for it to make sense to people, it's about being ready with the card to be able to go to a hospital or a health facility and be able to.
All right.
Yes.
We'll deal with more numbers when we come back and also look at a model for financial viability of our health service, including NHIS, but Mahama Case and the rest of them. Dr. Victor Bampoe is our guest. This is the point of view. Stay with us. We're still here with Dr. Victor Bampoe, who's the Chief Executive Officer of the National Health Insurance Authority. He's been in this position since January. He's done 10 months. He says for the first time we've crossed 60% coverage. He also says that now payments are more regular. Usually in our news cycle, facilities threaten that they won't give people service because they've not been paid. Are you saying that now you pay arrears within months, so that today is November 26th, that a facility would typically be paid, would have been paid for September 2025 already? So
they have 90 days to submit.
Okay.
You know, so sometimes they don't submit on the month.
Okay.
Some would have submitted for August by now, some for September. You know, that's the way it works. So there's that 90-day cycle. But as soon as they submit, within that month, by the end of the month, they are paid.
Wow.
But yes, so it's something that has not happened before. And that's why I was saying thank you to His Excellency the President and to the Minister of Finance and the Minister of Health, because we do have the resources to make sure that they pay. What it then does for the health providers is that it gives them some kind of predictability. Like I said, you know, in past years, you would have the private, especially the private health providers associations, going up in arms and saying that they need to withdraw services because they've not been paid. That is not happening anymore. And long may it continue.
A month ago, the MP for Wejagbawe raised an issue that some facilities were not getting access to health care because there was a certain software or a database that was not accessible to them. I think they call it the LMIS.
Yes.
And for that reason, a number of facilities that were to give service to people were not accepting the people. They were doing slow, whatever. What is the status of that? Has that matter been resolved? And have the facilities been able to basically onboard people?
So this is a classic case of being a victim of your own success.
Okay.
So what it is that the Lightwave system is an e-health system that was supposed to offer connectivity to all the health facilities. And we were hooked onto it so that claims were done or are done through that system and come electronically to us. By the way, over 99% of our claims are vetted electronically. Back in the day, it used to be
manual.
yes,
So
and it was very
much
tedious.
Yeah.
So remember that before this happened, we used to have systems by which we could, because you need to verify that the patient is who he or she says they are and all that. So there are ways by which you can use telephony and other means to verify. This has made it easy to verify the patient and then to submit their claims. So once there was this issue with Lightwave and it went down, it was a bit difficult for the health facilities to go back to the systems that existed before. And it took a little bit of time. And so we had to go out there, get all our staff to go to the health facilities to do two things: to remind them of the system that was there before, to remind them that even our system, the Claimit system, there is a user profile on their system that they can use. And thirdly, to guard against the cash and carry that we did. Because it is easy for someone to say, look, it's difficult for me to submit my claim, so you pay money. And all sorts of people, we are not angels, would use that as a platform to take advantage of patients.
So the Lightwave Health Information System not working, your contingency measure was to send your officers to the facilities.
Our contingency measure was to get in touch with all the heads of the health facilities to remind them of the methods they were using
prior to the Lightwave.
Exactly, which still work, and to put the people who work at NHIA at their disposal to help them if they were having challenges, but then also to safeguard the members.
This information came out a month ago today, 26th October or so, was when your team put out, your organization put out a release about the temporary hitch.
That's right.
So as we speak, are there any facilities that are doing out of pocket because of the Lightwave matter?
It would be presumptuous of me to say no, but nothing has come to our attention, and we're monitoring very actively because we think that to a very large extent the situation has become normal.
Because of your intervention to remind them of the way they used to work before, because as I speak to you, I think this week there was still a story about Lightwave. The dispute hasn't been resolved.
Yes, but there's a new system in place. Now let us put this in context.
Okay, please do.
Lightwave was supposed to cover 900 health facilities. I think 400, that's in dispute, but I think 450. Now we have over 5,000 facilities. So we are talking about a subset, albeit an important subset.
Fair enough.
I always like to ask
people
to remember.
Population. So we have 5,000 facilities, about 500 were affected.
Exactly. But even within those 500, we've given them specific attention to make sure, because like I said, 3 points to my vision. One of them is to curb illegal payments. So the whole office, when I say office, I'm talking about the 4,000 plus staff that we have. I was on the road. I went to the Volta region with my staff from head office. Everybody else, region, districts, making sure that we remind them of the way that things used to happen before Lightwave and making sure that we safeguard our patients.
So going forward, and this may be a difficult question for you to answer, but is it not better for you to have your own system than to depend on a third party? Because Lightwave is obviously not a government entity. right? And you are providing a public service, and a private company. Of course, the district has told us that this may have risks. So if they were to ask what's the best way to ensure that we're able to get the hospitals functioning better, record your claims in a way that is transparent, would you advise that they use a third party like this?
So I have a lot of things to say about this, but it will be mission creep. So suffice it to say that I think there's a new system in place. There were issues with the governance of setting up Lightwave, and I think that under the leadership of the minister, these have been corrected. There's a lot of merit and a lot of advantage to using that e-health system because it made things very quick. Some of our innovations are based on that, the e-pharmacy and so on. So it's a good system. We just need to safeguard it so that the mistakes that were made are not repeated. So classic case of not throwing out the baby with the bathwater.
Every week, when somebody talks about a healthcare condition, I hear inevitably an appeal for NHIS to cover. So last month or so, Speaker Bagwin met autoimmune people. Please, we beg, autoimmune and whatever, let NHIS cover. Another week we hear dialysis, NHIS should cover. Cancer, NHIS should cover. I want to first understand, do you have a list of official conditions covered?
Yes.
Is it possible for us to mention some of them?
Yes.
And then also, how realistic are demands that people make that add this one or the other? Almost every month I hear a new one.
So it's within their rights because, going to universal health coverage, illness has always been with us and illnesses will always be with us. So that's, I think the issue is about focus. I talked about Mahama case, for example, and the fact that non-communicable diseases are now taking us away, causing mortality. So there's a focus on it. I also talked about free primary health care and some of the things, So it's okay for autoimmune and others to advocate for it. What we do is that we have a process by which we look at what is the conditions. I remember someone approached me, a group approached me about lupus and so on, and fitting it within the right context. Nominally, we say the health insurance scheme covers 95% of all disease conditions. That's what traditionally...
Nominally?
Yes, that's what we say. But in reality, there are some that have been left behind. And it's not because maybe 20 years ago when the scheme was being put in place, some of these diseases were not
prominent.
Exactly. So things are changing. The important thing is for us to change with the times and to be able to pivot to meet some of the new realities and sometimes even be ahead. And that's why Mahama Cares, for example, is a beautiful idea because it's, and to my knowledge, it's one of the first decisions on the African continent where we are throwing a focus on non-communicable diseases. Now, I'm going to set my own question and answer. People ask, why Mahama Cares? Why is this not put under the NHIA? There comes a time in the scheme of things where you need to throw a focus on particular disease conditions. And I'm talking about specific
non-communicable diseases.
So for example, I'll give you one example. UNAIDS, where I used to work, a UN agency looking at eliminating HIV and AIDS. When it was set up, people thought, but WHO can do the same thing. The important thing is that UNAIDS has shed light on a particular concern, which at some point was killing millions of Africans and other people around the world. So in this case as well, this is a beautiful illustration of how under the president, we're having end-to-end health coverage. So you look at the x-axis as population coverage, and then the y-axis, which is service coverage. So the blue is actually NHIS as it exists.
So the blue is where you control?
Where we control.
Okay.
Now, if you look at I talked about the fact that 45% of conditions are now under chronic diseases. That's why the Medical Trust Fund or Mahama Cares was set up, to close that gap. Now, if you want to turn off the tap when it comes to non-communicable diseases, then you must be catching them early. That's where the free primary health care comes in. Preventive, promotive, diagnosing some of these illnesses quickly at the lower centers of health. So we have what we call end-to-end service coverage. We have population coverage where we are trying to get to 100%.
So free primary health care is at the base?
Is at the base.
And this is mostly at the lower level facilities?
CHIPS compounds, health centers, maternity, and even the polyclinics. That's free primary. NHIS is the regular health facilities. What the Medical Trust Fund is doing is providing the training, the equipment, and the general environment for some of these non-communicable diseases to be taken care of.
So does that mean that if Mahama Cares works, it will put less pressure on you because it's raising funding for diabetes, for the so-called, now we have a double disease burden, as they say, the higher level lifestyle disease.
Yes.
So is that sort of taking some pressure off you?
You mean when it works, not if it...
I mean, yes.
Yes.
So that it's because you have a funding mechanism for the blue.
Yes.
And he's raising funds for that through a different means.
So it's the same funding for health. You see, so the 3.4 billion, for example, this year.
Yeah, capping. Some goes to that.
Yes.
Okay. And is it administered through the blue?
No. So it goes directly to...
Because if I go to say, I don't know, give me a hospital, Ridge Hospital, and suspected diabetes, who will pay for it? Will it be this or this?
So you would go with your card
for this. Good.
And then under the regular diabetes management, you could still stay with this. If you do get complications, so you get diabetic retinopathy or nephropathy, which then gives you kidney failure, then you are pushing into that.
So if somebody's on dialysis,
yes,
will they be covered by blue or green?
By green eventually. But you see,
okay.
but we shouldn't even be too focused on that because it's what we call a continuum of care.
I see.
So you can, once you are covered, that's the most important.
No, I want to understand how the green functions operationally. I know how the blue works.
Yes.
I go to a hospital, I present my card, I'm on treatment. Consultation is covered.
Yes.
Some medicines are covered. Sometimes even inpatient can be covered for certain kinds of conditions. So I want to understand, how will this guy work?
So this guy will work because you've gone under NHIS, now you need dialysis. But you are not able to pay for the dialysis because you know that the chronic conditions, and why this is important is that within maximum of a year, most of the households where people have chronic conditions suffer some
pain. They become impoverished because all the money is going into...
Exactly. So once you are identified, you go into that, you see, and then your dialysis is being paid for. Ultimately, for example, we cannot keep paying for dialysis forever. Then we're looking at where kidney transplants, renal transplants.
So more high-level things.
Yes, but so it's a step-by-step journey of 1,000 miles.
So does the person have to apply to be covered by that? Or once you are a member of this and you get to a certain stage, you get transferred to that? So
once again, I can explain, but it will be good for my sister Obo.
No, because you sit in the center. Because this thing you're doing right now, the blue is in the center.
Yes. I'll come to this. But so they have what we call patient navigators who will then identify those who need,
to be put on that.
Exactly.
But when you say NCDs, for those who are not health people, let me just try
So chronic diseases, stroke, cancer, renal failure, diabetes, hypertension, and quite a number.
And these are usually, you have to keep going.
Yes.
Because the treatment requires regular medical.
Exactly.
What is the white doing here?
So the white is what I talked about earlier. We would wish for all the population to be covered. Right now we are at 60%. We are pushing against these user fees and the co-payments, where people go and they don't have a beautiful experience because they are asked to pay out of pocket. So eventually, success would mean that the whole of the middle layer is covered by blue.
Oh, so you want to reduce the white?
Exactly.
To
the barest minimum.
Do you have a year in mind when you want to do this? As we sit here now, this is the condition we have. Can you do this in 3 years?
We hope that we can do it as soon as possible.
Wow.
And we have measures in place to try and do that. Yeah.
This is quite interesting. We'll take a break. When we come back, I'd like to find out more about technology and a few issues because there's a concern about the multiplicity of cards. Senate have a card. Of course, they say the Ghana card is the main card. Is this guy's card going to yield to the main card? And then there are a few other issues. Stay with us. Welcome back. Tonight, we're speaking to the Chief Executive of the National Health Insurance Scheme, Dr. Victor Bampo. Prior to this, of course, in the Mahama one, he was the Deputy Minister of Health. He's worked in various places, the Global Fund, UN/AIDS. He was country rep for, I think, Kenya. And he's done many, many things in public health. So your whole life, so by the way, did you actually practice as a doctor in consultation? Or you were, because you look like you've become like a health administrator type of person.
So there are more than 16 specialties, and public health is one of them.
Okay.
So it's not every doctor sits in a clinic.
So you're a public health specialist?
I'm a public health specialist.
But did you study at Kolebu? Where were you trained?
Yes, I'm a class of 93, Kolebu, and then I did my public health in the US at Johns Hopkins.
So do you actually work in a hospital?
Oh, of course I did.
I
yes. Oh, no, I did. Yes. So during the training, I worked at Kolebu, and then I worked in several...
But you opted for public health?
Yes.
I see. So,
yes.
So you like, you are not into, you don't care too much about consulting and carrying medicine for people?
I think early on I decided that I wanted to affect thousands of people, hundreds of people at the same time. And there are people who love to do internal medicine. But I must tell you that actually in our setting, in the healthcare setting, especially to be a doctor, the highest form is actually when you are a clinician. So I remember, and I say this with all humility, when I was in school, I think I was quite good at internal medicine. So one day after I started my public health career, I went to buy some medicine at a pharmacy. And one of my professors, Professor Matekole, he saw me, he said, I hear you are doing public health. What a waste.
What a waste of a fine brain. You should be a clinician.
You know, but I'm fascinated by public health. I mean, and these kinds of discussions. You know.
I was at a program organized by the College of Physicians and Surgeons, and somebody said in Ghana we are into sickness care. Every time we talk about health, where is money for treatment? You mentioned prevention, promotion before palliative care. Why do you think, is it the business entities that make, because in Ghana every time we talk about health, hey, we don't have medicine, we don't have money. But we should spend more time saying eat right, exercise, sleep. You don't even need to fall sick.
Yes.
Of course, people will fall sick.
Yes.
Because not every sickness that comes from lifestyle. But there's a lot of conversation around money to spend to treat sick people.
Yes.
As against telling healthy people how not to get sick.
Exactly.
Do you agree that we need to spend more time on that?
Yes. I mean, this whole thing about medicine as food and food as medicine. Yeah. So I think, and I talked earlier about the mindset shift.
Yeah.
And so that's part of what we're talking about, wellness, looking at the promotive aspects. It's not gained too much currency. And it's not only in Ghana. I've been working in many other countries. And it's more interesting to put up hospitals and to put, that's been the tradition. Now we are trying to dial that back a little bit and make sure that people don't get ill in the first place. I think that's the way.
I suspect that people have built hospitals, so they want people to fall sick. So every time we're talking about, let's buy medicine, let's buy syringes. But I think, or is it that when people don't fall sick, people don't have any work to do? So it's like we have to buy medicine. I don't get enough coverage on media around healthy lifestyle and good diets and all the things you need to do to prevent some of the particularly communicable diseases.
Yes.
Because, I mean, yes, NCDs may come because population changes. But cholera and these type of things that you are supposed to...
But Bernard, actually the non-communicable diseases need the preventive, promotive even more. Because it's the lifestyle changes that are causing this. Back in the day when people used to walk to their farms, they were very healthy.
And they were eating okro and abedru. Now we are eating fried chicken.
Exactly.
And the trouble with me is that it's happening in poor communities too. So in the past, we used to think these things were rich people's diseases. But now you go to local coastal communities, they have communicable diseases. And yet people are also having strokes and hypertension in those poor communities. And
at ages that will blow your mind.
What is the problem? What's causing that?
Now we have people 11 years old, they have hypertension. I saw somebody who had prostate cancer at 31 years old, and it was a stage 4 prostate cancer.
In the past, this would have been much older person.
I mean, if you go to the literature that I used in medical school, it says that you need, prostate cancer, it's after you are 60 or 70.
Wow.
Now you can't take it for granted.
Things have changed.
It's because of what we eat and, the environment and the things that we are breathing in and, all sorts of different things are causing this now.
Your membership has grown. There's a big issue around consolidating cards the government has tried to optimize this by saying that there's a single source of truth called the Ghana card.
Yes.
So that the chip embedded card has all your details. But a lot of you and your colleagues, Senate and all, you still have cards. I think Senate have tried to yield so that the Ghana card becomes the card you use. But I think your card is a different type of card.
No,
right?
we are still working very hard with the NIA to make sure that the Ghana card is the single card.
Okay.
Yes, we have a program with the NIA where we are trying to make sure that we synchronize the cards. It's going a bit slower than we anticipated. That's why you will still see that our cards are still in vogue and being used. But eventually we'll phase out our cards.
So there'll be a point where my Ghana card will have all the data.
There are many people who do that now.
Is it?
Yes, yes.
Oh, wonderful.
And in fact, some of the digital tools that we employ, like the *929# or the My NHIS app, you can actually do that linkage yourself. Yes, you can try it. And after the program, I'll help you to
*929#
or My NHIS, app. We can try to make sure that your card is revalidated, and then you can link it to your Ghana card.
The current government doesn't seem to believe that Zipline was a solution to any major problem, because yesterday we were told in Parliament that the company is going to close some of its centers. And we interviewed Dr. Titus Bayu, who says they are using the thing to convey exercise books and things. This was presented as a major innovation in delivering healthcare at the last mile. You are one of the technocrats in healthcare for this government. Why don't you want Zipline to continue?
So, I have my own views, and let me first say that I will not add a single thing to what Professor Bayo said. I completely agree with him.
Really?
I remember in Geneva in 2009 or 10 when Zipline came to make a presentation. At that time, I was working for the Global Fund to fight AIDS, TB, and malaria. There was a board meeting. Zipline is fantastic. They've used it in Rwanda and so on. But like you remember, I talked about things being fit for purpose, and I talked about the Toyota Vitz and the Rolls-Royce model. And so, if what Professor Bayo is saying, that is being used to carry mosquito nets and is being used to carry condoms and things, then I think it's at an expensive. It's the cost of carrying those is not worth it.
Really?
Yes. So
the head of the health committee, the ranking member,
yes.
Dr. Ayuefrie, says people will die if Zipline shuts down those 3 centers. So he believes that Zipline must be allowed to continue.
Yeah, yeah. So once again, I'm not armed with all the details. So I'm just giving what I've heard in the news and all that. But I believe that, like everything else that we use, because especially now we have, we don't have all the resources that we used to have. Donors are pulling away and things. We must make each dollar, each cedi, stretch as far as it can go. And I think there are people better versed than I, like the minister and so on, who are looking at this, and they think that this is the, I don't think that they've said, and the minister said in Parliament, that they are not cancelling. I think they are looking at how they can make it more efficient.
There's a 175 million debt that has not been paid. I think government hasn't paid them. And they are saying that it's affecting their financial viability. Yeah. Therefore, they are shutting down 3 operational.
So they are shutting down, yes. Yeah.
But why wouldn't you tell government to pay them? Since there's so much money made available for health, including the 3.4 billion, don't you think we should spend some to pay the Zipline people?
No, I'm interested in making sure that our health facilities are getting funding. That's my mandate, and that's what I'll focus on.
When the U.S. government decided to withdraw funding for certain areas, USAID obviously has shut down. They were doing a lot of work in health. How materially has that decision in the U.S. affected the pool of money for healthcare delivery in Ghana?
So initially there was a jolt, but remember that the president then asked that we make some money available.
Yeah.
So we put money in the formula, in our budget, and currently there are many of the sister organizations under the Ministry of Health that have benefited, Ghana AIDS Commission, the Food and Drugs Authority, and a few others who have come, and through the NHIA, there's a part of our formula, our budget, which is for the Ministry of Health. And the minister has directed that they receive funds. So it's not as bad as it could have been, because we've been actually proactive in making sure that we plug.
Since the Africa Health Sovereignty Summit happened in August. What substantially have we done? Because I think the president hosted that to say we have to start thinking about raising money to finance health in Africa.
Yes.
Has anything materially happened between August 5 and today since that?
And by the way, you did a brilliant job hosting that. And then after that, in September, we were in New York, where it was revisioned as the Accra Reset. And we had even more stakeholders coming in and bringing in their ideas. Now, where we are at is that, you remember in New York, the president said he was going to form a certain council where, there would be that's where the thought leadership will reside, where people would think about how we move forward in practical ways, form some kind of subcommittees looking at different financing, all the subcommittees that would make the work go forward. And that's actually in process. I know that there are meetings going on, and very soon the names would be mentioned, and then it would go full steam ahead. You know that Madam Helen Clark was here, a few days ago, even talking about the Accra. There's been a lot of interest across the continent and across the world, yes. And it has put Ghana in a certain light. And we are happy that NHIA is actually privileged to be part of this under the Ministry of Health, because we can use the funding that has been given to us to demonstrate some of the things that we are talking about.
Wonderful. So you have 60% of the population, 20 million. When will we come back to 80%? This is my last question.
Yes, we're pushing hard, and I just wanted to say that the 20 million are those who are active. On our database, we actually have 28 million people on the database. Yeah, but we don't believe in just expanding coverage for expansion's sake.
All right.
We believe in making sure that when you have the card, it works, and it works well, and you get the maximum benefit. That's the reason why we're there.
I wish you well. Thank you.
Thank you very much.
Dr. Victor Bampoe is the Chief Executive of the National Health Insurance Authority. They run the health insurance scheme, and they are moving very quickly. We have been privileged to have him on the show for his first interview since he was appointed. Thanks for watching. We'll see you next time. Have a good night.